presencia del doctor Hedley Quintana. Él es médico, epidemiólogo con doctorado en epidemiología del Instituto Karolinska de Suecia, precisamente donde nos encontramos y somos colegas de formación. Y está trabajando como investigador en el área de salud y evaluación tecnológica sanitaria del Instituto Conmemorativo Gorgas de la República de Panamá. Entonces él es un experto aquí en nuestro país vecino y pues es un honor para mí presentar a uno de mis compañeros del doctorado en Ciencias de la Salud del Karolinska. Entonces aquí tenemos al profesor Hedley Quintana y pues vamos a pasar, como esta es una actividad bilingüe, entonces pues invito al profesor Quintana pues primero a presentarse en español y ya después empezamos la actividad en inglés propiamente. Muchas gracias por estar con nosotros, Hedley. Bienvenido virtualmente a Cali, Colombia. Espero que nos pueda visitar físicamente.
Sí, ojalá que sí. Bueno, para los que no me conocen, mi nombre es Hedley Quintana. Soy un médico panameño, como mencionó el compañero Fariño, y actualmente estoy trabajando en el Instituto Conmemorativo Gorgas de Estudio de la Salud, en un departamento que tiene un nombre mal puesto, ¿no? Ese nombre no es correcto, pero bueno, es el nombre del departamento porque al inicio no se sabía qué nombre ponerle. Eso fue muchos años muchos años antes de que yo llegara al departamento. Pero las actividades que actualmente yo realizo son actividades relacionadas con la epidemiología de enfermedades crónicas no transmisibles. Tabaco, principalmente, un poquito de diabetes, un poquito de hipertensión. Actualmente estoy introduciendo un proyecto al Ministerio de Economía y Finanzas para ver si me dan algo de platita para ver un tema relacionado con el acceso a los servicios de salud. Okay, we'll start speaking English. My name is Hedley Eugene Quintana. I'm a medical doctor I studied in Panama. Then I studied a master thesis in Södertörn Högskola. It's a university placed at the south of Sweden. And then I studied a Ph.D. medicine in the Karolinska University of Karolinska at the Environmental Medicine Institute, IMM in Swedish. Right now I'm working in the Gorgas Memorial Institute for Health Studies. As I mentioned in Spanish, I'm working in a department with a very wrong name. Most of the activities related to my job are related to non-communicable diseases, a bit of diabetes, a bit of hypertension, almost no cancer, and mainly tobacco control. I am submitting a grant proposal to be for the Ministry of Economic and Finance of my country related to health access. I hope I get fortunate to get this grant approved. I will try to share my screen. I have a presentation in Spanish language. Sorry about that, but I will speak in English anyway. This presentation, this presentation is regarding to the diabetes mellitus. It's an ugly disease. Its prevalence, Spanish we put on awareness, but actually it's awareness in English, and control in Panama. From data from the National Health Survey for Health, so the first Panamanian Health Survey, that took place in 2019, from June to December that year. Just a couple of months before the pandemic was declared in our country. Diabetes is a very ugly disease. It has a large number of complications. There are acute complications and also chronic complications that I will not enter into details. vital organs like heart, kidney. Eyes are not vital, but they are also affected. And blood vessels, nerves, all of these things are affected by diabetes. So my main target is more than like the blood vessel, but they are everywhere, and most of the damage are related to the blood vessel, except for the eyes, that the lens is also affected directly. Worldwide or globally, 422 million people have this diagnosis of diabetes mellitus, and among them, 62 of them live in the Americas region. In 2019, it was the sixth cause of death, or main cause of death around globally, and the second cause of disability around in the same place, the world. During the years 2000 and 2001, it was, I could say, for several years, not only 2000 and 2001, it's for several years, it has been the fifth main cause of death in our country, Panama. And before the ENSPA, there is no known study where the awareness and the control of the disease has been assessed. I mean, in a national scope. Before ENSPA, there was a pre-study mentioned in this presentation, but this study was only underwent in 2 provinces. At that time, there are 2 provinces. Now there are 3 provinces that have a large amount of the population. There was a previous study called the National Survey of Quality of Life, Internacional Health and Quality of Life, sorry, that was assessing the diabetes on national basis, but only with the clinical history, because there was no lab data in 2007, and it was 5.4%. As I mentioned, these are the 2 previous studies. The first one was in 2010, and the other one was in 2019. Both of them have lab data, but for the previous I mentioned was only the provinces of Panama and Colon. Right now there are 3 provinces. Panama province was split 3 years later in 2 provinces, the West Panama and Panama, and Colon. And Colon, sorry, and the national scope. These are the biomarkers that was assessed in ENSPA. This is the target sample. We didn't reach the target sample. I actually want you to look to the right side. In the right side, you see that there are several lab data, but for this study, in particular, we only focus on 2 lab biomarkers that are the glucose, the serum glucose, the fasting serum glucose, and also the A1C hemoglobin portion. These are different definitions. We mentioned that diabetes, that is defined as a medical history of diabetes, fasting glucose above 126 milligrams per deciliter, or a proportion of hemoglobin A1C greater than 6.5%. This is the definition of people with diabetes divided by the total population. Then we have awareness of diabetes. There are people, or unawareness, I mean, people with diabetes that is not diagnosed. I mean, people have the level of glucose above 126 and or the proportion of hemoglobin A1C, of glycated hemoglobin, greater than 6.5%, but who doesn't have a previous diagnosis of diabetes among all the people with diabetes as defined previously. There are two definitions of control. The first definition is a bit quite strict. That is the both of in the numerator of this definition are people with diabetes diagnosed and we have hemoglobin A1C less than 6.5%, divided with the people with diabetes diagnosed, and the ADA definition, American Diabetes Association definition, have two definitions also, but we assume that the people with diabetes have a long lifespans, and for these people, the definition is people with diagnosed diabetes with the numerator, meaning hemoglobin A1C less than 7% among all the people with diagnosed diabetes. I make a comparison with the pre-studies, but don't pay so much attention to the left side of this slide, or more attention to the right side of the slide. These are people who are 18 years older, living in Panama, and these people, 12.4% have diabetes mellitus. And if we divide by sex, 9.8% of males have diabetes mellitus, and 14.5% of women have diabetes mellitus. If we, next. Okay. This is the same information, but instead of using segmentation by sex, this is segmentation by age groups. 0. As you see, it increases with age. Okay, it's important that you notice that I will not do so much data. You can see it by yourself. You have to see the right side. We disregard the left side because it's not really also comparable. We show both this to have a comparison. When talk about the unawareness about diabetes mellitus, people, 37.4% of people having diabetes are unaware that have this condition. This proportion is slightly higher in men and women, but the difference is not statistically significant. This is the same information regarded by sex. It's a very difficult to assess this information by sex, because the sample is a bit sparse, but you can see that it's very unlikely that people in extreme life segments have are unaware of the disease. More people are living in, how to say, in between 30 and 59 years old. Who are productive. These people are likely to are not aware. Half of them are not aware of this condition. This is a bit tricky. I will pass this fast because it's not really so important, this slide, and I will go directly to the ADA criteria for control. I only selected people for control who has the previous diagnosis of diabetes mellitus, because if you are not aware of the disease, there's no way you can control it. Simple as that. You are unaware, you cannot do anything, and the only thing that you can do if you're unaware of the condition is to start treatment and start to control the condition. But once you are aware of the condition, or you know you have the condition, a bit less than half, 47.7% of people nationwide who has the diagnosis of diabetes has the diabetes under control according to the ADA criteria. And there are differences between male and female, but these are very small number in the sample, and it's very difficult to assess any statistical significance. If we go to the age, it's a bit more, even more difficult to assess this difference by age. And this is the last slide. These are some factors that are associated to the incidence of diabetes mellitus. One of them is age, family history of diabetes mellitus, excess weight also is associated with increased risk of diabetes mellitus in both men and women, but the socioeconomic status, educational level is only important for the association of diabetes mellitus men. These are factors associated with decreased knowledge of diabetes mellitus. Age and family history of diabetes mellitus are people who have this factor as age increases, and also as people have family history of diabetes mellitus are more likely to be aware of having this condition. Regarding, we compare ENSPA and PREFREC, that is the study, they are more aware of the condition compared to people in ENSPA, probably because they are people related to urban settings and kind of thing. And in women, the use of tobacco products, the life ever consumption of tobacco products are more likely that make the women aware regarding the knowledge. Women are less likely to smoke than men, but these women are more likely to have some knowledge about the condition, but it's not happening well. And these are some slides related to the field work of ENSPA, that is this latest survey. I was not in all of the pictures, but here I am, here in the upper right, when we have the column province. But I was in all the different provinces. I'm not in all the photos except for this that is in the lower right, that is in Herrera. I was not there. This lady with the gray hair is Dr. Roa. That is the main or principal investigator of the ENSPA survey or ENSPA project, and the other lady in the upper with the blonde hair is my boss for the department. And these are other people that are related, are very important for the execution of this survey. So this is I think the last picture. These are some pictures related to also to the field work related to anthropometrics measurements. And I think that's it. And this is the link. It's in Spanish language. So sorry, I know I have to speak in English, but this website have information of the ENSPA study, and the only thing that is written in English in this you have to the documents part, see, and here these are actually the papers related to ENSPA. All of them are written in English, except for the latest one related to the enforcement of the national rules related to the healthcare in patient. It's a very interesting paper, but it's written in Spanish. But the other one are written in English. This is the first one related to the central obesity, and this is the one I'm referring to is the latest one written in English, and this is the latest that is written in Spanish. So this is the last, the last slide, and this is the ENSPA studies. I would like to know if you have any question related to this specific paper published in the journal Medicine. At the beginning, have a very high impact factor, but right now it's a bit low. But it doesn't matter. You can read it, and you learn a bit more about my beautiful country.
Okay, thank you very much, Dr. Quintana, for your very interesting oral presentation. And I have some questions for debate the discussion here in this space. And I think that at the beginning we are going to speak in English about the questions and answers. And by the end, maybe we can do some short summary in Spanish for have also this point of view. Congratulations, it's very challenging to do this kind of research in our countries in Latin America. Could you explain us some logistics difficulties and challenge during the field work of your study?
Okay. The first thing before doing there are different phases for the development of this and any survey, of course. The first one is the planning phase. Then we have the piloting, the pilot test. There are a few figures that appear to the pilot test, and we learn a lot during the pilot test. One of the things that we learn, first, some things the piloting is the most interesting part, and the most of the learning that we have in this survey. I mean, for the technical point of view, is more related to this pilot test. This pilot test was developed in the east. Panama is divided in things that are provinces, but for the Ministry of Health perspective, they have a thing they call the health regions that are the same as the provinces, except for the province of Panama, that is divided further in 4 health regions. San Miguelito, metropolitan area, San Miguelito, metropolitan north, Panama North, and Panama and East Panama. So the different definitions. So the piloting we divide. We have several places in East Panama, and we were working we simulate different areas or geographical areas that, according to the country, there are 3 geographical areas: urban, rural, and indigenous area. And I was working as I was simulating to be the supervisor in the indigenous area for this piloting. I have a very inefficient survey taker, horrible, this guy. And I was working, we divided in different houses, and when I enter with this survey taker was horrendous, this guy, and I have to become a surveyor. So, and I make the questionnaires. First of all, at the same time, we have a IT guy that we were working in the real thing. We work in Android tablets. We actually capture data, but for this piloting, we horrible work with paper things. And I become a surveyor, and start asking questions. And one of the thing that we noticed, I was in a house with a household with 10 people living there, and these 10 people, there were a family chief that have to answer questions related to the house, and we write down a roster, and we selected a random 2 person, one person age 15 or older, another less than 15 years old. And the funny thing is that there were 3 persons when I took the survey, and one of the person that they actually doesn't know who live in that place. They know the names, they know the birthday were needed for filling the roster. And the funny thing, they show me a real large hand of IDs and we did have no ideas. I started to write down the roster, and the funny thing, there was a little child, 8-year-old, something like that, and he by the top of his head, he know all the people in the roster, and I know someone, Pepe, Maria, la la la. I was writing that down. The other thing that we learned during the piloting is that we plan to in the team use one person to do the anthropometric measurement, weight, height, this kind of thing. And during the piloting, we learned that it doesn't work. We need 2 persons in each team because they are very large. They're not so heavy, but they are large, and this measurement was done inside the household. And it was very interesting story, though. Later, when we collected all the data, we wrote down the report. And this report was a very large report. We're talking about 800 pages, very crazy thing. And we spit out a lot of crazy tables using R, a lot of tables from the data. And then we have with this table, we have to write down the findings and this kind of thing. We work with talking about like 8 months, something crazy like that, during the pandemics, in order to have some product to deliver. It was so crazy. It was a lot of things to do. There were some administrative issues that I was not really aware of, but it was a lot of work, and the final product, I think, was very, very nice. And also the database is a database that you have no effort to manage. No, the dictionary is not needed because you have working with SPSS that have the information of the variable, the values. It's a very nice experience, I think, and it's a very exhausting to work with this survey. Also, the lab data was another story. Something else you want to ask?
Yeah, of course. How was the acceptance of glucose blood test? Because you need to take the blood samples, and how was the acceptance in the population
well, it's among
the participants of the survey?
Yeah. They were accepting. It's a very large acceptance for this lab data. The issue with the lab data is that for this survey, due to the cluster sampling techniques and so on, we survey the actual data was 17,997 persons, but there was no money to do lab data for all these people. So the decision that was taken is that there are some number of people in some primary sampling units. It's all described in Spanish. And according to this number of persons, there was it's about 1/3 of this number, 5,000 in adults and 2,000 and something in children. We actually have the data, but there was a large acceptance for blood tests. There's no problem with that, and also for the issue related to the anthropometric measurement. There are a few people that rejected. But most of them, majority, because this is the nature of Panamanians, we love to have blood drawn. There's no problem. We don't have any problem. I don't know in other countries, but we are very accepted for this. I could say something like more than 90% of the people who have were selected for labs. They well, in children was very low, not because the people refuse, because there are houses without children, and the number of households without children was it's like 35% of the households that have children, and the number go very down, go to hell. But the issue was they went down not due to low acceptance, it's more that the number of children was actually low using the techniques that we use.
Okay, very interesting. Thank you. And The World Health Organization, they have a surveillance system for chronic diseases based on surveys. They call that STEPS. Did you use a similar approach to that for Panama in relation with the STEPS methodology?
The methodology of questions, I mean, NCD question, because there's a lot of information in ESPA, was based on STEPS. We're talking about the lab data, how to say, the anthropometric measurements. These were based on STEPS. There are other areas related to health access and these kind of things. There are other different sources. But for NCDs was based on STEPS.
Okay, perfect. I have read your paper, and there are some tables on results, and I am is hypertension the comorbidity of diabetes or a predictor of diabetes? Because you have used hypertension as a predictor or explanatory variable. Do you think that is a comorbidity instead? On what do you think about the analysis there?
Tricky. It was very tricky. That both of them have common risk factors related to diet and hypertension, but this is the reason. I'm not really sure if one is a consequence of the other, but hypertension, I mentioned a predictor is true, but it's not really. I don't think diabetes is a predictor, because in order to do that, I have to have some kind of timing and so on. I'm not really sure it's a good idea that I have put this thing in the model, but it's true. It's true. The thing that they have different risk factors, simple as that. Common risk factors, and this is the reason. The reason probably I put it together. More like I was trying more for the issue related with control and awareness more than that. But for what to say, for the incidence of diabetes, I don't think so. I put in the model anyway, but I don't think so. I don't think they are related.
But the prevalence of hypertension, it was also very high.
Yes.
What do you think? What do you think in the research team? Do you have other papers in relation to hypertension specifically?
Yes, we have it. I would say we have one paper dedicated to the hypertension. It's very high, but we think it's more related to the aging of the population. The Panama people are not so young. They have an increased longevity, and this is the reason we have probably high hypertension. It's not really. And the other thing is both for diabetes and for hypertension, we ask several questions related. They are in a step related to the use of medication also, in order to what to say, detect people who have hypertension. Even the history of medical story of hypertension, and also the use of medication. Both of these things we use, and this is the reason perhaps this too high, but it's very high. And also the other factors like obesity also is extremely high in Panama. It's very funny to see that 1/4 of people have normal weight in Panama, according to the body mass index. And in that group, this is the first paper, depending on the definition, we can have a half of them could have obesity according to the abdominal circumference. This is the reason perhaps we have these very high values of these crazy things. The good thing about Panama is that we have a thing that they call the end game. That is the prevalence for current smoking that is very low, but I could say that it's compensated by the high body mass index and low physical activity, and what I say, low physical activity. This combination is very terrible in Panama. No, it's only with the urbanization and these kind of things.
Okay, great. And this is a methodological question for more details, because maybe some of our students need extra explanation. In the paper, there are two kind of numbers of the numbers of the sample and the numbers of the population.
Yes.
Could you explain that in more detail? Because when we do survey methodology, we have these two kind of approaches. We have the N, the small N for the sample, and
Yes.
the big N, the capital letter N for the estimation in the population. Could you explain us about the differences?
Well, I wanna say that it's simple, but the idea is very simple. The N actually is the actual number of persons that were surveyed. The little n. The big N is the inverse of the probability that this person represent the actual population according to the estimations of the latest two census that were from 2010 and 2000. 2000 and 2010. Sorry, these are the two latest census. In 2023, there was a new census, but we don't have access to that data at the time. But using these two census, you make a projection, and you project the population with these characteristics, and you divide the people according to different strata, and you calculate the probability of this sample. So the inverse of probability, and this is the weight that this person has. Is the way that we calculate the big N or the population. As far as I understand this issue. This kind of calculation is not done by Gorgas. It was done by the National Institute of Statistics. We don't do it. Right now, the guy that do this kind of calculation is working with us. But this is something very recent. We're talking about a few months ago. This guy is working with us. Let me see. He mentioned something about his wife, but I think his wife's better. Had an allergic reaction a couple of hours ago, but she's fine. She got better with some drugs. No? But this is the issue with the sampling. We don't used to enter in detail to this. The way that for the design, for the analysis, we use the weights given by this guy from the National Institute of Statistics and Census, the actual name. That is part of the National Controller Office, no? So this is the way it works, no? And this question that you're making is very common all the time at this presentation. I have to reply to the same question related to that.
Yeah, because it's a question. Maybe some people they think they could think that you have a huge sample size, but it's not.
It doesn't work in that way.
The sample size is smaller, and it's the estimation of the population.
Yeah, but it's an estimation of the population, exactly. And this estimation is you have to have some confidence interval for this estimation. So this is not the actual value. So you have to, this is the reason when you read the paper, you see like three numbers: the mean, how to say, the estimation, also the range or the interval with this 95%. That this calculation is done with I use the survey package from R, but in SPSS you have this how to say, this it's a very tricky in SPSS. You have to have this module of this package in order to work with sample, and in Stata is very easy also. It's very easy. I say perhaps the easiest I could say is Stata. It's data or state of Stata. So no, what you wanted to do is
in Stata.
Stata.
Okay, great. And how the results of your study have supported change in the health service management in Panama?
I would like to say that it's a huge impact, but you know, NCD is not so sexy, and people doesn't care so much about this thing. As what to say, as a side note, I could say that the Department of NCDs in Panama is two persons, only person working on all the NCDs. That is absolutely crazy. When we talk about other diseases, we're talking about statistics, whatever, it's a huge department. With this, only two of our colleagues working, and I'm very sad. And it's not a situation, this issue is not for Panama. It's, I think all of the world, I don't know in Colombia how it is, but I remember I was in a meeting in Washington in 2017, something like that, and exactly the word that I use with this guy forensic. No, this thing is not sexy, and nobody want to enter into it. I hope it actually foster change. I have a little hope because in the last, the last scientific meeting that we have this year, there were some people working in new guidelines for handling diabetes. One thing, this guy told me, working in the guideline, oh no, I only have one data from Prefect, and I don't. No, don't worry. You have more data. You can read the paper. You can read the report, and get fun. And the other part, you can actually go to the ADA or the World Diabetes Federation, wherever you are. But for the Panamanian data, you have to look the ESPA. That's the latest. The latest result that we have.
Perfect. Okay, and I don't know if some of the participants, do you have more questions to Dr. Quintana?
Yes, please do so. You're welcome.
Also in Spanish, Mónica, David, Brian, Hannah. Si tienen preguntas también en español, podemos pasar a español para la última parte si quieren.
Sí, lo desean. Español es mi lengua materna, así que nuestra lengua materna. Pero bueno, Spanish, English, a little svenska. No svenska, nej. A veces lo molesto con eso.
Bueno, entonces quiero pasar a esta última parte en español, pues dar las gracias de nuevo al doctor Hedley Quintana por acompañarnos en este espacio de la Escuela de Salud Pública de la Universidad del Valle, en Cali, Colombia. Y sí me gustaría que volviera a explicar esta pequeña parte metodológica, pues porque este es un espacio académico, entonces cómo es esa diferencia entre el N de la muestra de una encuesta poblacional y las estimaciones de población a partir de esta pequeña muestra, porque tal vez en el artículo pues confunden algunos N mayúscula que aparecen muy grandes y quisiera que esto quedara claro y aprovechamos el espacio académico.
O sea, el tema, o sea, primero antes de hacer esta N grande, N minúscula, eso no lo dije en inglés, pero sí lo voy a decir en español, uno tiene que hacer una cosa que se llama el diseño muestral. Si uno hace un diseño muestral, uno divide básicamente las diferentes o sea, en primera instancia existe una cosa, el censo, existen lo que son segmentos censales. Estos segmentos censales a su vez se conforman, son unidades primarias de muestreo. Entonces las primarias de muestreo se eligen al azar dentro de todo el país, pero tiene que haber cierta cantidad de estas unidades por las diferentes regiones de salud, que como dije en inglés, la región de salud y provincia es exactamente lo mismo, excepto para la provincia de Panamá, que se divide en cuatro. En cuatro regiones, ¿no? Y los datos de la ESPA, cuando uno hace había olvidado esa parte. Después que uno hace ese esquema de muestreo, uno básicamente hace una serie de pasos aleatorios de selección. El primer paso, eso está escrito en español en la página web. En primera instancia se elige lo que es las unidades primarias de muestreo. Después, dentro de la unidad primaria de muestreo, se tiene que elegir una cantidad de casas, digamos que son un número de 14, y dentro de cada casa, al azar, se elige una persona que tenga 15 años o más y otra persona menos de 15. Si es que hay. Si no hay, nada más se elige una. Entonces, se hace la encuesta de una cantidad N de personas, N minúscula de personas. Y cada una de esas personas está básicamente dentro de una banda de edad, de sexo, cómo es que es también el área geográfica, distrito, corregimiento, etcétera. Y hay una probabilidad dentro de la población de que esa persona sea elegida. Vamos. Entonces, la idea de eso es básicamente utilizar el inverso de esa probabilidad y multiplicarla por la población que le corresponde a ese grupo de personas. Y en base a eso, entonces se hace lo que es la expansión de las personas, ¿no? Y hay que tomar en cuenta que ese número es un número básicamente, vamos a decir, que tiene cierto grado de precisión, que eso hay que valorarlo. Hay que tomar el esquema de muestreo y ese esquema de muestreo en todos los software, uno tiene que básicamente indicar que básicamente usted va a trabajar con una encuesta y hay diferentes métodos, en cada software tiene su método y uno básicamente va a obtener la N, o sea, esa N mayúscula tiene un rango de error que
Ujú.
implica básicamente los intervalos de confianza de esa N. Una cosa que me acuerdo, no lo mencioné en inglés, pero lo voy a mencionar en español, es que me acuerdo que yo hice los cálculos en R, y entonces cuando fuimos a SPSS, en SPSS hay dos formas de trabajar con muestra expandida.